So, Sunanda is associated with Pallium India as the regional coordinator in our state facilitation team. She belongs to the state of Odisha and is presently based out of Pune. She has an MBA and master's degree in sociology with more than 20 years of working experience in different sectors. She has experience in the healthcare sector for the last 5 years, and she has worked with UNICEF and also with different government projects in the state of Odisha, Gujarat, and Maharashtra. She can communicate in the following languages like Odisha, English, Hindi, Bengali, Marathi, and extendable Gujarati. Thank you, Sunanda, for being here with us. And over to you for further session facilitation and faculty introduction. Welcome, ma'am.
Thank you, Sinia, and a very, very wonderful evening to all of you. Namaste. As already Sinia has introduced me, my name is Sunanda, and I really welcome you. It's great to see all of you here. On behalf of Pallium India, I welcome you all to this volunteers training program, virtual, which is going to continue till Friday. And before we start, I just wanted to tell all of you that, as we all agree that in palliative care setup, the role of volunteers is equally important as the doctor and the nurses. And all those who are doctors who have joined here, they'll agree with me. And those who have already worked, I know quite a few of the participants here, so I am very sure they'll all agree. So that is the reason why, we are trying to take up this kind of trainings and train all of you in palliative care. And we want more and more volunteers to join and help us, because this is a teamwork and it is not an individual's work. We need people like you to join hands and do more great works in palliative care field. So can we go ahead with the faculty introduction, Sinia?
Yes, Sunanda.
Okay, so I'm really glad and delighted to introduce today's faculty, who is Dr. Deepak Sudhakaran. I can just start with his professional background. So he is a specialist in community medicine, and he's working currently with Pallium India. He has completed his MD from KMC Manipal, and he has also completed his 6 weeks certificate course in palliative medicine. So other than this, as a person, you're going to have a really good time, because he's a very enthusiastic person. He's full of energy, and he really wants to share his knowledge and wisdom. So I think you all are very lucky to have him as the first speaker of this particular session. So I request Dr. Deepak to take over. And once again, I welcome you all, and very good evening to you. Please enjoy the session. Thank you very much.
Namaskaram, everyone. Thank you so much, Sunanda ji, for that very generous introduction. But let's move on straight to the session now. We have hardly 1 hour with us, and palliative care is a whole world by itself. Introducing palliative care is not easy because of so many components involved in it. But at the same time, let's try looking at what it is. So I'll start sharing my screen. If you could tell me if the screen is visible.
Yes, it is visible.
Yes.
Right. All right. So one thing is, more than taking notes, I can see some people have already started taking notes. I would really appreciate if all of you can turn on your videos. It gets very monotonous during virtual sessions that I look at myself and my own presentation. I get to look at myself at least twice a day at home, which itself is sometimes bearable, sometimes unbearable. But now it would be glad if I can look at many new faces over here. Can we switch off this meeting chat? This chat box, yeah. Also, I would request all of you to be as active as possible on the chat box. Okay, and in case you are finding it difficult to handle the chat box, you can unmute yourself and speak out. Okay, all right. So we'll start off. I want you to. There is a picture which is visible on the screen right now. I want you all to tell me your observations or reflections about the picture which is there. Can you use one sentence or 1 or 2 words to describe what you see on the picture right now?
A sad patient.
All right. A sad, I don't know if he's a patient yet or not, but he's a sad person for sure. Okay, trauma.
Someone with anxiety.
I would say a lot of turmoil going on in the mind because
Lot-
there are a lot of turmoil.
All right, lot of turmoil. I'm getting some comments as well. Confused, emotional, and in pain. Confused, multiple negative feelings, multiple emotions, trauma,
Depressed.
turmoil. Yes.
Depressed.
Distressed. Yes, distressed. Right.
Depressed.
Yes, distressed. A disturbed face and melancholy. Dry land which is getting water. Okay. That water doesn't look like a pleasurable way of a rain which we can enjoy. It looks more like a storm which can destroy. Sad, a lot of thoughts in the mind. Hopeless, sadness. Yes, thank you so much. I want to continue seeing this kind of a participation. Like you have been saying, we can switch off this one, this chat box. Yeah, right. So like you said, this is a person who you can look that he's having a tear in his eyes. Definitely something is bothering him. He's looking little withered, and you can see what is happening inside him. There is a forest, there is a fire which is going on, which is killing the tree. At the same time, there is a lot of cloud and a storm going on with a lot of thunder and rain as well. But at the same time, you can see that the sand below is parched. That means there is no life in it, right? It is a dried off soil. So you can see that this is a person in every way. He's withering away and moving away from life. Yes, he is confused. He is sad. There is turmoil, and there are multiple issues probably which this person is handling. And that is what is usually the case when we undergo uncertainty, right? When uncertainty is happening in our life, what happens within us? Outside, we may smile and show everyone that we are in a good space, but inside us, many a times when we are faced with uncertainty, this is the image. If there was a way to capture what is happening within us, probably this would be the image which will be captured. And I want you to know that this is what happens to people who get life-limiting illnesses. And when their health gets affected by it, and they turn into or we start in the medical lexicon, we start calling them as a patient. Tell me that, should we call this person as a patient alone? Is he just a patient? Yes, chat boxes, please. Is he just a patient? Yes, we may be healthcare providers, but imagine if somebody calls us a patient. Are we just a patient with having just a disease? Or do we have many more dimensions to us?
Many more dimensions.
Absolutely.
Your
Everyone,
spiritual-
yes, everyone will agree that there are many more dimensions to us as a person. Now, when I'm saying these things, I always assume myself in the picture, that I am a person who is having a disease right now. And I'm imagining what are the things which can get affected. My social life will get affected. My personal life will get affected. My financial life, my emotional side will get affected. There are so many different kinds of distress which suddenly I will start going through just because an illness happened to me. Sometimes this illness is curable. Sometimes this illness is non-curable. By now, you must be knowing that, we are on the way to become a capital for non-communicable disease. Can we close this chat box? I'll handle the chat box from here, no problem. Right. So we are on the way to becoming a capital for non-communicable diseases in the country. And non-communicable diseases are the ones which contribute maximum to the need of palliative care. All right. So now we need to look at, we spoke about it in an overall sense of manner. Now we want to look at what is it that we want to address, what are the aspects which we need to address in a patient. And if we need to address things in a patient, we need to understand what is health, right? So what is health? Can somebody come and tell me? Either on the chat box or, yeah.
Overall sense of well-being, be it physical, emotional, spiritual. So it's a total feeling of well-being, right? And
Right?
I think that's somewhere captured in the WHO definition
Right.
as well.
Yes, Dr. Pankaj has also unmuted himself. Yes, sir. Please tell me.
It's social, mental, physical well-being.
Right. So multiple dimensions again. So this is something which we have been learning or hearing since day one in from our school age onwards. We have been hearing, right? Whenever it comes to health, we are saying that all these dimensions is a complete state of physical, mental, social well-being, and not merely the absence of disease or infirmity. Can we close this? Will record, deny, or
Kindly note that the participants cannot record sessions.
right. So, so we have been looking at this, right? But let us ask practically. Every time we were a patient and we went to a clinician, or when we went to a doctor or to a nurse or to anybody in the healthcare sector, depends, if you're a psychologist or psychiatrist, it depends on certain situations. It may be different. But let's see in general, when a patient goes to a doctor, okay, in looking at this thing, looking for support with their illness which they have, which dimension do you think is addressed? Yes, chat box or unmute. Which dimension is usually, no need to open the chat box, I have had it here.
Physical.
Physical, okay. Physical. Emotional, okay, one person is in emotional. Till now I've got a lot of physicals and emotional. Okay, some have got a good doctor. Dhruva.
Physical and mental.
Physical and mental, yes. Social.
It's all three, sir.
All three, yes.
I would also say all three, because I think just all of them are interdependent on each other. So it's just not about being physically active, if you're mentally disturbed, then obviously it takes a toll in your physical and your social
Right.
well-being.
So the
I would
question
say
is that
all of
when
them
a
are married.
person, so the question is when a person goes to a doctor in today's world, majority of the times, which is the dimension which is most commonly addressed?
Physical even.
With the kind of time the doctor has, it's mostly trying to diagnose the physical ailment, and then whatever time they can give a little bit of an emotional touch, which plays an important role.
Right. So that's what. So all of you would agree that a majority of the times it is only and only the physical dimension which gets addressed. Sometimes the emotional or mental component gets addressed, and majority of the time the social aspects are completely left, right? Are not looked into. Maybe because of practical reasons. There is not enough mechanism. There is not enough people. Even if we ask about social problems, what is it that we can do? Yes, Ms. Sonali Jadhav, you have raised your hand. You want to share something? All right. So most of the times we are not able to do much about the social aspects of life. But I am sure all of you will agree that what happens beyond the four walls of the outpatient department or of the operation theater is what matters to a person the most, because his life lies outside those four walls. It is only for the disease that he would have come there, right? And a doctor is supposed to address health. But what are the aspects the doctor is able to address, or the healthcare system is able to address? It is usually confined to physical, sometimes physical and mental also. Okay, so let's look at where all of you have now. This is a volunteers training program, and how is it that you can come into the picture? We'll be looking more into it throughout this session. So before that, what is palliative care? So palliative care is an active holistic care of individuals across all ages with serious health related suffering. So there is something called as serious health related suffering. How we can address that in a holistic way? By holistic way, we mean physical, social, mental, and sometimes spiritual also, if we have the bandwidth to do that. That brings us to the next thing. What is SHS, or serious health related suffering? So serious health related suffering or health related suffering is serious when it cannot be relieved without medical intervention. So there is a medical intervention which is required, And it comprises, this medical intervention comprises of physical, social, spiritual, and or emotional functioning because of severe illness. So an illness, a severe illness which affects all these aspects of a person. Okay, and there is an intervention which needs to be done medically as well. That is when we call this as a serious health related suffering. We'll look in more into detail about this. And what is a severe illness? It is having high risk of mortality. Mortality means death. It negatively impacts the quality of life. Okay, and it is not just the patient whom we are talking about or the person directly affected. Many a times it is also the caregiver who is stressed out because of this. See, many of you must be working or would have worked in healthcare sector or are currently working in healthcare sector. Can you tell me the term which is universally in India used as for the person who is along with the patient? Along with the patient, there will be one person. What is the term used for that person who is along?
Attender, caretaker, caregiver.
Caregiver.
Attendant.
Bystander.
Okay.
Most
So
of the time, relative.
most of the time, somebody was saying
Relative. Patient relative.
patient relative. Yes. So most of the times, or many of the times at least, I have studied in 2 medical institutions, and I know for a fact from other places also, attender or bystander. These are the 2 terms which is very commonly used by everyone, you know, in general. It is called, they're called as bystanders. But are they just attending to the person, or are they just standing by the person? There is so much more happening with their own life itself, right? So we always address them as caregivers. They are caring for the person and they are trying to give that care in whatever they can, in whatever way they can. So there is a caregiver stress also over here. And in palliative care, we focus not only on the person who is having the illness, but also to the caregiver who is there along with this person. And if the person is admitted to a ward, or like in our NGO over here, then it is only one person who is the caregiver. But for Pallium India, where we work, majority of our work is home-based services, where we drive all the way to the person's home, sit with them in their house, and then provide palliative care. So we look at not just the person, but the caregiver and the family members also. It may be immediate family members, or it may be extended relatives who are directly involved with taking care of the person with the illness. So we get involved with them also because we want to provide active, holistic care, or the ideal way in which a person, a health professional would have loved to give health care to a person. That is how we try giving it right at the doorsteps of the person. So that's about that. That brings us to the concept of total pain. So pain doesn't always mean physical, right? If there is something going on wrong with our lives, even if physically nothing is wrong, we can be in pain, right? A very common term which we use is that I am in pain, sometimes due to disease, sometimes due to life situations around us. So these are the 4 dimensions which we will look at. There are many more dimensions to it. You can further break it down to more dimensions. But in general, all the dimensions can be categorized into these 4 basic categories. That is physical dimension of health, psychological dimension, socio-economic dimension, and spiritual dimension. And like one of you were saying, it is very true. See, gradually as minutes pass by, people switch off their videos. So I would request people that please stay on the video. It gets boring for me. So then, like one of you was saying, that it is true that all these things are interdependent to each other. See, one day you have got a headache. Okay, you had a long day of work, you have a headache. And you came at home thinking that your spouse will give you a hot cup of coffee so that you feel better. It is expected sometimes. But you reached and you see your spouse is just watching television with his legs on the teepot and chilling, not even asking how your day was, or not even bothered about asking you if he needs to do something for you or not. Won't your headache increase? I'm just using an example. It may be your kids creating a ruckus at home, or it may be something else going on, somebody who is not enough understanding enough with you. Suddenly you will find that your headache has increased. So obviously there is a psychological, looking at the circumstance, there is an impact which happens on your physical symptom as well. Many of the situations, you see, especially in the kind of patients we see in palliative care, the diseases are life limiting, either in quality or in quantity of life also. And majority of the patients or people in our country don't have health insurance. It's a fact. So they start doing out of pocket expenditure for getting treatment for these illnesses. And what happens is slowly they drain their finances out. Above 60% of our population is still below poverty line. And I believe that most of us, whatever we get exposed to on the television screen are highlights which comes from metropolitan cities or big cities like that. But I want you to know majority of our population lives in those areas which is not captured by any television screen. It is in the rural areas. And all the burden which you see, these kind of burdens where a person gets completely financially drained out of treatment for their illnesses, that is their socio-economic status gets affected. If somebody would have read or observed, in 2018 there was a scientific article which was published which told that over 55 million Indians were pushed to below poverty line just because of health expenditure. That is out of pocket health expenditure. That is no insurance, health problem, went in for health expenditure. And then of course, then there is spiritual dimension also, where there is an existential crisis which happens. All of us in general, Indians are God fearing. I'm not being judgmental, but in general, India is a country. There are many religions in the country, and there are so many cultures in the country, and everybody has got a belief system which is their spirituality. And somewhere a person who starts getting affected by a serious illness starts asking God, why is it that I am going through this? Did I do something wrong? Many of them, they don't have any habits like alcoholism or tobacco use, or they don't have any such habits which can be damaging, and still they undergo illness. So they start going through an existential crisis of their own, which we look at under the spiritual dimension. So this is called as total pain. And this is what we want to highlight is illness related suffering is more than just the physical symptom alone. There is many more dimensions to it, and everything needs to be looked at. We may not be able to do everything about all the dimensions, but at least it needs to be inquired for so that we can know which are those areas where we can contribute. And this is exactly where volunteers come into the picture. See, if you look into these 4 dimensions right now, I can very confidently say that a medical doctor, or a doctor for that factor, a doctor is responsible only for 25% of health, only the physical dimension. The remaining 3 dimensions are areas which needs to happen in the society, in the community, through volunteers like yourself. Because these are all, the other 3 areas are areas which needs a lot of contribution, and they contribute to 75% of a person's health related suffering. And that 75% is what I'm looking at when I see all of you joining us. Shall we move ahead? Is it okay? Can somebody come? Can you give some responses on chat box, or give me a thumbs up or something? I just want to see if there are people sleeping off in the evening. Usually afternoon time is the time when we encounter this, but beyond 5 o'clock, I think you can have your cup of coffee and continue with the session.
We
Right.
will go ahead, sir. We will go ahead.
Right, great. So let's go ahead then. So always there is a multidisciplinary approach. Okay, there is something called as correcting the correctable and always having a family discussion. Now I'm sure that at least people who have tried or who have come across palliative care somewhere, what is the impression of palliative care? Can you tell in few words on the chat box, or you can unmute yourself? Impression of palliative care. Today is the first session, I believe. Some of you who have got exposed to palliative care already I'll let you pass this question, but others, what comes to your mind when you hear the term palliative care?
It's a dignified care or lot of emotional support, which is part of end of life care.
Okay, part of end of life care. Okay. Others, somebody else also, please.
Most of the people coming for palliative care is found that they have been rejected by the hospitals, most probably, except the physiotherapy units, except the physiotherapy patients. They expect that their end is better in a palliative unit. Thank you.
All right, so the end is better in a palliative care unit. I am getting some comments also. It's fighting the losing battle. It is end of life care, support to a suffering person when further treatment is not possible, care at the end of life, following a critical illness, improving quality of life, reducing pain, aims at improving quality of life and death. Right. So I would say that at least 6 or 7 out of the 10 answers I have got is related to end of life or something to do with death. Okay, patients and other medical colleagues put us as the last option, which can't be more wrong. So palliative care is quality of life, right, to give a holistic idea. So the impression is that it is related to end of life care. When a person is nearing towards their death or on their deathbed, that is when palliative care comes into picture. But then look at this, look at the central point in this. The first principle of palliative care, or if you want to elaborate palliative care, we call it as palliative medicine and supportive care. One of the central points is correcting the correctable. That is very actively, we want to see what is correctable in a patient. Right now, I'm consciously using the term patient because most of the times when the person comes to us for help, it is for symptom management. And in symptom management, we have to identify what is correctable. It may be the symptom itself or it may be the underlying disease. So many a times we take a multidisciplinary approach where I may take help from a physician, I may take help from a specialist, I may take help from a super specialist. So it is always a multidisciplinary approach to correct the correctable. And always there is a family discussion where we try identifying what, like we were looking at caregiver stress. So why the caregiver is stressed? One, they have their own practical issues. Second, they are not able to understand what is going on. So many a times we have to walk them through the process about what the disease is, how will it proceed, what can we do. So always having a family discussion is something which is extremely important. I think Ms. Preeti has raised your hand. You want to share something?
Yes, I wanted to ask, does the correctable?
You became muted, ma'am.
Can you hear me now?
Yes.
Yeah. So does the correctable aspect depend on the financial conditions of the family?
So we'll come to it. We'll be looking into it. Of course, sometimes it does, or many a times it does. All right, but we'll look into it. So always we have this kind of an approach in palliative care where we are very actively looking at what can be done for the person. But having said that, I have to agree that not all setups or all facilities have the bandwidth to do all these things. Okay. And we are looking at mechanisms to ensure that we can do that. We can do as much as possible for a person who is suffering. So let's move on further. So palliative care is definitely not just terminal care, as we very popularly put it. It is not about adding days to a person's life. It is about adding life to a person's number of days he has. So yes, as soon as the illness happens, we want to start coming into the picture so that we can add to the quality of life of that person. So who will be your team in this endeavor? Yes, there are doctors and nurses, there are social workers, and there are volunteers. These are the major 4 people who get involved with providing different dimensions of palliative care. Okay, but like I said in the previous slides, that 75%, mind you, 75% of the work can be done by volunteers alone, because little bit of exposure and little bit of training in the psychosocial aspects, spiritual aspects can ensure that you can address majority of the suffering. Then a doctor's expertise is needed only for few of the things where there are symptoms involved or there is medical expertise involved. So yes, this will be your team. Now, one question which we want you to ask is, when a patient comes in front of us, okay, as a doctor, whom are we treating? Are we treating ourselves, that is, our own self as a caregiver, as a healthcare provider, or are we treating the family, or are we treating the patient? So there are these 3 categories possible who we may be treating. Let's look at it with some real life examples which I have seen in my past. So 47, this happened in Karnataka when I was over there. This was a 47-year-old lady. She has got a history of lung cancer. She has done chemotherapy and done with it, was not effective. She has got multiple metastasis, that is, it is spread out everywhere. And her organs, multiple organs are involved. She has got kidney injury. Okay, she's anuric. Anuric means there is no urine being produced, which means that she is somebody who has gone in for a kidney failure or a kidney is not working. And there is multiple, her bones are also having cancer. It is spread from the lungs. Now, this was the situation of the person. Okay, I'll tell you her story. Her husband came and cried to us saying that they sold their land for doing the chemotherapy. They had some land which was being used for agricultural purposes, and they sold that land. They had a shop, so one room in their house was a petty shop for selling things. They had to sell that room and the petty shop. Okay, and the last thing remaining was her ornaments. All her ornaments were also sold. Now this person has got a child also. If I am not wrong, he was 12-year-old son, and their future also has to be looked into. I mean, the kid's future also needs to be looked into. Now here is a person in whom everything was tried, and to make it more graphic, the person's chest area where the treatment was done was completely ulcerated. That is, it didn't have skin, and the person was in severe pain. And one day she passed away. One evening in the hospital itself, she passed away. What was left behind? There's a husband who is a small shop owner. Now he is looking at how he can rebuild his life. A son who was studying in the 6th standard. Now they are looking at how, how to secure his future, probably for his education and things. And he has got a debt of 2 lakh to the hospital where the treatment was done. Now the thing was, after a few rounds of chemotherapy, probably it would have been evident that in which direction the treatment is going to, or is it becoming effective or not. Now, despite of this person having multiple spread throughout her body, which is usually, I'm just going to put it bluntly without any niceness to it, it is usually a death sentence where all organs are involved, Many organs are involved. Treatment has been tried. Everything is done, but still that the people kept grabbing onto a hope that somewhere there can be a cure. It was only a question of giving them a different direction. But at the end of the day, whom did we choose to treat over here? I would say that the doctor chose to treat himself that day by giving more and more options, despite of knowing that probably it is hopeless to put this person through this or put this family through this process. So this is what was left behind of the family. Let's look at another case. This is also from the same place where I was working. She's a 64-year-old. The caregiver is a neurosurgeon. Okay, is a neurosurgeon, very highly qualified doctor. It's his mother. So she has got CA lung, cancer lung, which is spread to her brain, which is spread to multiple bones, and she's in a semi-comatose state. That is, she comes awake sometimes and remaining time she's in a coma. The part of her brain which is supposed to keep her awake and everything is damaged. And she's in an ICU for 3 weeks now. You know how an ICU situation is? In an ICU, always the lights are on. Always there is some monitor beeping sounds, beep, 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 happening from multiple monitors. Unknown people walking around with masks. And there is this lady who is lying over there, who is also having a mask on her, and she's having multiple tubes all across her body. Few times when she had come awake, she told that she wants to be outside. She doesn't want to be in an ICU. She told this. But her son, being a neurosurgeon, he is very adamant that he wants her to get the best care possible. And he wants to go to the maximum extent possible to save her. Okay, now I'm talking of a family member, a caregiver who is a very highly qualified doctor who is unable to accept that
it's the Respironics filtration auto CPAP.
That's something that the end is near. Because of him, I go to the extent of saying that his mother suffered actually. Being amongst unknown people. Can we just unmute?
25 to 30 के बीच में हम आपको.
Right. So amongst unknown people, here is an elderly lady lying, wanting to spend whatever time she comes awake, wanting to spend with familiar people around her. And in this is another case. This is a case where the treating doctor ended up treating the family member who is the caregiver, or the son was treated, because this is not what that patient required. Right? So what was left behind? A mother who wanted to be with her family during her final days. But we ended up treating the son rather than the patient. So this is one very important question which we need to ask as healthcare providers. Whom are we treating? Are we treating ourselves, the family, or the patient? And many a times we need to find a middle path where at least the next two, like that is the family and the patient, can be addressed. That brings us to the story of another real life story from Pallium. He had cancer. He was having a form of a head and neck cancer, which is very severely painful in this region of the head and neck. He was getting some form of disease modifying therapy, that is chemotherapy and radiation therapy. Has a wife, 3 children, and an elderly mother. Now, what are the things which is going on inside a person's mind? We may just see, okay, a patient of this, having this disease, this symptom. But what is it that the person is going through? Will he be able to pay his medical bills? Will I be able to provide for my family from tomorrow? I don't want to eat or talk. There is too much pain going on. I'm unable to sleep. Am I going to die now? There's so many questions which cloud a person, right? And these are the questions, these are some of the questions which leads to the first image which I showed you. That first image which leads to that kind of a mental state in a person. And I am not talking about the well-to-do people. Yes, the well-to-do people also go through these things. But I am talking about those above 65% or 60% of people who are below poverty line, who don't have health insurance, who don't have technical knowledge, who suffer the poor public health system. And they, like Ms. Preeti was asking, do finances affect? Yes, they are the kind of people who get affected. Of course, we have schemes like Ayushman Bharat. It has got a lot of, some aspects to it which will need to be looked into. But yes, there are certain schemes which gives decent amount of coverage. But I will tell you, in a state like Kerala, where the health literacy is supposed to be very high, in a state like Kerala also, the penetration of Ayushman Bharat is very poor due to whatever reasons. I don't know if it is just politics or something else. I don't understand politics, but for whatever reasons. So that is the reality of the situation on the ground. And this is where I'm sure that if I had a volunteer as a neighbor or in that society who had the technical knowledge, or no need for technical knowledge, just the general knowledge of how a person in this situation can be helped out, a lot more could have been done to alleviate suffering, isn't it so? And this is all we are trying to do through these kind of training programs, where you can become aware of what are the issues which a person can go through. At the same time, develop a compassionate community, where if your neighbor is going through an issue, it is not that they are alone. You will also contribute towards making sure that they can be as comfortable as possible. The reason being, very frankly speaking, in today's world of urbanization and nuclearization, two terms which we need to be aware of, everybody is running towards an urban kind of living. And what happens in urban kind of living? Nuclearization of families. That is, more and more people are living by themselves. That also means that the elderly population is becoming more and more alone. I have two elderly people of my own at my home, so I know what I'm talking about. That more and more nuclearization leading to a lot of other issues among elderly people as well. Especially in these circumstances, I am very well aware that tomorrow I may be that person who will need help, who will need that support. Certainly, it would be great if I have a neighbor or a friend or somebody in the community who will be able to help me out with the small things in my life. I don't want major decisions, but the small things. It may be to buy me grocery. It may be to make one-time food and give me. It may be to carry me to the hospital, provide me lift to go to the hospital and bring me back. It may be, right now there is an Aadhaar updation going on, Aadhaar updation drive by the government. So to update that Aadhaar, I may need somebody's help to go take me to an Akshaya Kendra. It may be small things like that, which is what becomes burdensome for a person. See, I may become prepared for death. Many a times we see people became prepared for death. But it is that process towards death. That is, every day there is so many small things which causes a loss in dignity for a person. So what is palliative care? Palliative care, we are looking at addressing all those aspects in which a person may lose his dignity and contribute towards it. So how is it that for this person we made total pain into total care? Let's look at it. For the physical dimension, there is something called as an opioid trial, which is we use an opioid medication, which is a very powerful form of a painkiller. We gave that medication to this person, we tried it, and he got 100% pain relief. Mind you, he was a person who hadn't slept since months. And this is not because he has not been visiting a hospital for months. It is only because the doctor also was not aware that there is something like this which can be done. And many a times, I feel funny when people have got so much aversion towards painkiller. I don't know why. Even they don't know why, actually. They think that some major thing is going to happen, but even doctors prescribe by saying that don't take unnecessarily or prescribed only for 2 or 3 days. What about the remaining days? For a person who is having a lifelong illness, what about that? So these are questions because of it, which comes because so much more training needs to happen, or so much more awareness needs to happen. A psychiatry consultation was facilitated. We didn't have a psychiatrist. Okay, but we have a well-wisher who happens to be a psychiatrist. So what we did is that we facilitated a psychiatry consultation for his wife, for both of them, but for his wife as well, because we wanted to look at caregiver support also. Now, this person was a daily wager. So 1 day missing work means next day's money for meals is not there. That is the situation. So socio-economically, what did we do? There was a volunteer who sponsored the education of his children, who took care of his children's education. He promised that I will take care of the children's education. I don't remember exactly, since till 10th or 12th standard or something was covered. After that, of course, we will continue giving education support through other volunteers. And a poultry business was set up for his wife. Something simple, which the wife, even an unskilled person, can be trained to do. We keep identifying these kind of things. So for her, what was done is a poultry business was started, which was supported for her, sponsored and supported for her, and she earned her living through that. Small amount, but at least she doesn't have to beg in front of somebody else. And spiritually, when we took care of the other dimensions, we made sure that the family is having some dignity of earning their own living and being able to give back to society. See, up to an extent, we always think about what we can get from society. But after a point, we always think, what is it that we can contribute back? It may be to our children, it may be to our spouse, it may be to a neighbor, it may be to larger society. Depending upon our capacity, we may be able to contribute something back to people. So over here, giving back to society, the family was having a business of their own, which meant that they are doing something for themselves and for the people around them as well. So this is how we converted total pain into total care. So what was the old concept of palliative care? See, over here, you can see that the diagram above is the old, the diagram above is the old concept of palliative care, where we keep doing the curative management. Okay, that is, the main doctor keeps treating, and then when nothing else can be done, they will give to palliative care. So what happens is, the person often has a miserable end to their life. Okay, because the disease has progressed so much, and whatever things could have been intervened earlier on, that was not done. So they come to us in severe pain and severe difficult symptoms, difficult to treat. It makes the job difficult even for a palliative care person. And below is the current concept. Here you can see that the first point is the point of diagnosis. That is, the diagnosis has started. At that point onwards, palliative care begins. But as you can see over here, at the beginning, the palliative care is less. Majority of it is curative care. Okay. But as time progresses, you can see the gray part, that the curative care options become lesser and lesser and lesser, and the palliative care option becomes more and more and more. That is, we do things to alleviate the suffering. Physically, the doctor did whatever he could do, but then through trained network of volunteers, we are able to do much more for them in the community. And this is where I would like to mention that we depend heavily on our volunteers. From our headquarters in Trivandrum, where we are placed right now in Kerala, a team of a doctor, a nurse, and a social worker in a vehicle goes to a faraway place, which we call as link center. That is, that center is linked to our headquarters. In this link center, everything is taken care of by a group of volunteers. That is volunteers like yourself in the future who are trained in palliative care, who can identify the needs of palliative care, who try doing activities in their locality like talking with college students, talking with school children, talking with other self-help groups, who can contribute to a suffering person. And they will be the ones who know that in their community who has got illness, who has got family issues because of the illness. And they highlight these points to us. And we provide medical expertise and social care, or we sometimes just draw an outline of the strategy for the plan and tell the volunteers to carry it out. So many a times these patients may require hospital visits. It is the volunteer who pays for the ambulance service, or it is the volunteer who may go with the patient to the hospital as a caregiver for the whole day. Because most of them end up going to a government hospital, and the government hospital will be so huge that the patient, if they go, they don't know where to go. The patient and the caregiver, they don't know where to go. They get confused and lost inside a big hospital. So the volunteer goes. The volunteer recommends us that, this family member, their daughter is about to drop out from school because they are not able to afford and they are too proud to ask. So we may have to actively do something to intervene. That is another form of intervention. So they are the ones who tell us what to be done and where it should be done. We are the only, we only go with the technical expertise to look at how these things can be done. Right? So the role of volunteers or community participation is very huge. And for whatever reasons we choose to draw boundaries. If something is happening to my neighbor, why should I bother? Which is a question. Very true. Why should we bother? That is one question. But other one side of us is that we always want to do what we can do for somebody else. It gives us a sense of fulfillment. It helps to the creation of compassionate communities. And if nothing, I firmly believe that only if I work towards this cause, tomorrow when I am in such a position, some random stranger, hopefully who is a trained palliative care volunteer, will guide me as to there are ways in which we can make your life slightly easier or slightly more comfortable. I will help you out with this. Don't be worried about it. At least to tell that much, I want a random stranger to be there around me. So in an effort to do those things, that is why volunteers training for in palliative care. With that, I will stop my presentation and pause for some questions or comments which you may have. Yes, please feel free to use the chat box. If anybody wants to unmute yourself, please feel free to do so, one person at a time.
Sir, thank you so much for a very concise yet very, very good presentation. I just wanted to know from you, sir, like I'm not a medical professional. I'm a teacher by profession. I teach sociology. So in case if I have to offer my voluntary services, what could be included as part of my voluntary services?
So for volunteers also.
Apart from you said that talking to students and all, apart from that. So.
Right. So how we usually design voluntary services is that we look at the area of expertise of the person also. One is there is a general volunteering aspects where we just look at certain things which needs to be done and who is free or who can do this. But other is there is always an area of expertise which everybody is, like you said, you are from a sociology background. So I will have to, so homework from my end will be to understand, and that will be taken offline, of course, will be to understand that what is it that you can provide as an expertise service, and identify which area you are in and connect you to a network of people who are into palliative care space, so that your expertise can be utilized for the betterment of that area. So that is how usually it functions.
Dr. Deepak, can I add, please?
Thank you.
Dr. Deepak?
Yes, Sunanda ji, please proceed.
Yeah. So actually, Ma'am Vinita, It's a good question. So in due course, like on the, I think on the Thursday or the Friday, you will be given a range of, activities that as a volunteer can do. So since today is the first day, so we'll go, as per the session. And I think on the Thursday or the Friday last day, you will all come to know what we have and you can pick up from there. Thank you.
Perfect.
Thank you,
Thank you,
ma'am.
Sunanda.
Thank you so much.
Yes, Miss Ravdeep Kaur, you had raised your hand. Yes, please.
Yes. So yeah, just like a comment, because all of us are here taking this training as volunteers, and I primarily for the last 10 years have been working into the public health space in the healthcare. So just a comment here that in terms of this term volunteer, we need to take it a little more seriously, right? Because I'm associated with some other NGOs as a volunteer, but when it's really needed, we see people will register, but when it's really needed, because it's volunteer, how we think about it is not paid. So then I don't need to be there when it's really needed. And that can be worse. It's best not to be a volunteer, but if you can't be available when, really there's a need, then this whole of this activity is kind of a waste, so just wanting to share that thoughts. It must be taken a little more seriously, because that's how we'll be able to make that difference for what we are all, taking this training.
Absolutely, yes. I mean, if, all kinds of people actually, some of them just want to learn, some of them, they are looking for some engagement, some of them looking at the larger picture. I mean, different kinds of people, of course, and the only effort which at least I can put from my end is right now to reach out to as many as possible, because for the population which we have, I'm sure that we will get good number of people who will get involved. And can we count on them? Yes, there are a few people whom we can definitely count on. But again, like you said, it all depends on the drive from person to person. So it is one thing to learn things and to actually bring it out
to
on the
execute,
field.
implement. Yeah, I'm just saying that
It is
little bit
different.
of more awareness, right? That
Right.
if
So
we are
that
all
is why,
here.
yeah, right. Very true. So that's why we always focus on what mechanism we have in place, so that the volunteer can feel, that they can do things, they can make a difference. And once they start doing the work or they start making an impact, then they become unstoppable, because they realize the impact it had on a person. So
Yeah, and also wanting to share, because this doesn't take that extra time, right? In your regular scheme of things, not
Absolutely.
wanting to talk big about that. Like, just I know of a colleague who just suffered a stroke on a bike, and it's been a year. So that day I just made that little phone call to ensure because he was hesitating to reach out because now he cannot, a little paralytic attack. So a home-based job, and wow, right? That's taken
Right.
care, because I've been seeing that now for a year, there's no earning and how the family would be. So
Right.
wherever, I didn't have to really go out of my way, but wherever you had a connect, if 1+1, you can just put them there. Doesn't take much, right? So it's only
Right.
about that awareness.
Right.
Yeah.
It can be as simple as just doing one phone call a day, one phone call a day to one patient and find out how they are doing. Or just follow up that, last time we had come, this is what had happened. How are you doing now? Or some other issue was there. How is it now? Is that issue still persisting? So many things actually. So it
Dr.
can be,
Deep,
yes,
yeah,
yes.
Dr. Deepak, with your permission, I want to take this opportunity to share something interesting.
Sure.
So, Tina ma'am, thank you very much. And I think she forgot to share that we already have a volunteers group for the state of Maharashtra, which is active since January. And she is very much a part of it and very active member. We have Parul ma'am. She's there in this participant list. So I want to tell all the participants from here who are from, who are from Maharashtra can join us, because we have every fortnight we have meeting, we discuss things, we take out options how you can help the Maharashtra people in palliative care. So and that's what I wanted to just share with all here. Yeah, thanks. Thank you. Over to you.
Right. So yes, please, more people who would like to comment or ask something. I'm all ears.
Thank you, sir.
Hi, Ajay. Please tell me.
But I asked you, I don't understand your language. I am Punjab and
All right. Ajay, I
Yes,
think you're
sir.
breaking in between. Okay, you said you don't understand the language.
हाँ जी सर.
अच्छा ठीक है, तो अभी इतना देर मैंने जो बात किया वो ढंग से आपको समझ में नहीं आया, बोल रहे हैं?
प्रॉपरली समझ में नहीं आया, थोड़ा बहुत तो समझ में आया.
ठीक है, कोई बात नहीं. अभी हमारे थोड़े बहुत हिंदी सेशंस भी होते हैं. सुनंदा जी, इफ यू कुड जस्ट नोट हिम डाउन.
सर आप कहाँ से हैं?
सर पंजाब से हूँ मैम.
ठीक है, तो हमारे जो पंजाब के लिए जो कोऑर्डिनेटर है ना,
हाँ जी.
उनका नंबर वगैरह हम आपको शेयर कर देंगे. ठीक है.
यस मैम. यस मैम.
तो वैसे तो देखिए ये सिंपल सा है जो सर ने बताया, वो अपने स्लाइड्स के थ्रू यही बताया कि जब पैलेटिव केयर की बातें होती है तो हम डॉक्टर नहीं है, नर्स नहीं है, कोई क्वालिफाइड नहीं है, फिर भी हम कंट्रीब्यूट कैसे कर सकते हैं, उन्होंने वही समझाया पूरा सेशन में, जो कि आगे चल के आपको और भी क्लियर हो जाएगा. सो अल्टीमेटली आप यहाँ हैं, इसका मतलब है कि आप पैलेटिव केयर से जुड़ना चाहते हैं, आप कुछ करना चाहते हैं सोसाइटी के लिए. ठीक है. तो तो उस हिसाब से आप अगर अपना फोन नंबर या ईमेल आईडी चैट बॉक्स में दे दें तो हम इट विल बी इजी फॉर मी, मैं अपने कोऑर्डिनेटर को पास ऑन कर दूंगी. और आगे अगर कोई हिंदी में होगा, एक्चुअली देखिए थोड़ा डिफिकल्ट होता है हिंदी में क्योंकि पार्टिसिपेंट ज्यादा मिलते नहीं है, सो दैट इज व्हाई हम लोगों ने इसको इंग्लिश में ही रखा है. तो लेकिन कोई बात नहीं है, हम आपके तक पहुंच जाएंगे थ्रू आपका ईमेल आईडी या फोन नंबर से. चैट बॉक्स में डाल दीजिए. थैंक यू. थैंक यू.
Ma'am, if you permit me, can I just summarize what was said in English, in Hindi for Ajay?
Oh, very good, very good. That will be nice.
So अजय जी, अभी सर ने मोटी बात ये कही कि जैसे कि जिंदगी और मौत तो अपने हाथ में है नहीं, तो जब लोगों को किसी भी उम्र में, मर्द को, औरत को, बच्चों को, बुजुर्गों को, किसी भी उम्र में जब कोई ऐसी बीमारी हो जाए या फिर कोई ऐसा मेडिकल कंडीशन हो जाए कि इंसान मतलब ना सांस ले पा रहा है, कई केसेस में जैसे यूरिन पास नहीं कर पा रहा है, बहुत बुरी हालत में जब इंसान होते हैं, तो ऐसे वक्त में जिंदगी को आसान करने के लिए, उसको एक अच्छे डिग्निटी से जीने के लिए जो भी हम कर सकते हैं वो पैलिएटिव केयर के अंडर में आता है. तो उसमें सर ने 2-3 बहुत बेहतरीन केस स्टडीज शेयर किए कि पैलिएटिव केयर किसके लिए हम कर रहे हैं. पैलिएटिव केयर क्या डॉक्टर्स के लिए है या परिवारों के लिए है या उन लोगों के लिए है जो बहुत ज्यादा बीमार हैं. तो मोटा मोटा कहने का मतलब ये है कि हम लोगों को अपने किसी भी ना किसी वॉलंटरी सर्विस से, जो इंसान बहुत ज्यादा तकलीफ में है, तो यूजुअली क्या होता है, जो बहुत गरीब लोग और जिनको कैंसर हो गया है, ऐसी बीमारी हो गई है जो ठीक नहीं हो पा रही है, तो उनको इकोनॉमिक प्रॉब्लम्स भी है, आर्थिक समस्या भी है, पारिवारिक समस्याएं भी हैं, सामाजिक समस्याएं भी हैं, कई लोग हॉस्पिटल जाने की हालत में नहीं है. तो इन सब चीजों को मद्देनजर रखते हुए एक वॉलंटियर के तौर पे हम किस तरह से अपना सर्विस ऑफर कर सकते हैं. तो मोटा प्रेजेंटेशन में इसी बात को सर ने बताने की कोशिश की. पैलिएटिव केयर का एक ही लक्ष्य है कि किस तरह से हम जिंदगी को एक डिग्निटी से, बेहतरीन तरीके से, इवन मौत सामने है तो भी कोई बात नहीं, बेहतरीन तरीके से कैसे हम हेल्प कर सकते हैं लोगों को.
विनीता जी, इसी को हम वॉलंटियरिंग कहते हैं.
अच्छा.
हेलो.
तो आपसे जो हुआ वो आपने किया. This is exactly what we are saying.
Thank you.
She's already contributed. First session में she's already contributed.
और अगला सेशन के लिए अभी आपका नाम आ जाएगा. हिंदी सेशन के लिए हमारा फैकल्टी.
मैं बहुत कम जानती हूँ, वो भी मेरी फ्रेंड डॉक्टर प्रिया हैज इंट्रोड्यूस्ड मी टू दिस, तो बस धीरे धीरे समझने की कोशिश कर रही हूँ. मैं बहुत डरती थी पहले, मतलब पैलिएटिव केयर के नाम से मैं बहुत डरती थी, बट धीरे धीरे ठीक है.
थैंक यू मैडम.
आपका वीडियो ऑन करेंगे तो हम आप मैम.
Very well summarized.
Right. So I think we have overshot time. 6 बजे तक ही मुझे टाइम दिया गया था, लेकिन मैंने आपका टाइम थोड़ा ज्यादा लिया है. If there is nothing more which somebody wants to ask.
सर और भी समझा दो.
और आगे समझेंगे. अभी तो पहला ही दिन है, 4 दिन और है. सीखने के लिए और काफी कुछ है, जानने के लिए काफी कुछ और है। और अगले 4 दिन में जो होने वाला है वो तो खाली ट्रेलर है, पिक्चर तो बचा है देखने के लिए। तो वी विल प्रोसीड फर्दर और वेरी हैप्पी टू हैव सच एन इंटरेक्टिव बैच। ऑफ कोर्स मैं रिक्वेस्ट करूंगा कि आप लोग आगे से और भी इसी तरह से एक्टिव रहिएगा और वीडियो को हमेशा ऑन रखिएगा। एंड लुकिंग फॉरवर्ड टू सीइंग अ लॉट ऑफ यू। जब भी आपको चांस मिले जरूर यहाँ पे आइएगा। और सुनंदा जी हैं आपके साथ हमेशा कांटेक्ट में रहेंगी। तो इवन नॉर्थ इंडिया में कहाँ ऐसे एरियाज हैं जहाँ पे पैलिएटिव केयर है और जहाँ पे आप कंट्रीब्यूट कर सकते हैं। दीज थिंग्स वी विल सी हाउ टू मेक इट रीच आउट टू यू। So with that, Sunanda ji, I will hand over to you.
Yeah, thank you very much, Dr. Deepak. Actually, मैं पार्टिसिपेंट से ये रिक्वेस्ट करना चाहूंगी कि आपने जो भी सवाल पूछे हैं कि कहाँ पे पैलिएटिव केयर सेंटर्स हैं और डिटेल्स, तो आपको लास्ट डे सब कुछ मिल जाएगा। आपको मैंने कॉन्टैक्ट लिस्ट मिलेगा और आपके रीजन वाइज कोऑर्डिनेटर्स के कॉन्टैक्ट नंबर्स, ईमेल आईडीज मिलेंगे, सेंटर्स कहाँ पे। तो अभी आप समझिए कि आप पैलम इंडिया के एक परिवार के सदस्य हो गए हैं। तो आप बिल्कुल चिंता ना करिए, ट्रेनिंग खत्म होगा फ्राइडे को, बट हम जुड़े रहेंगे। और हिंदी के लिए आप जो भी आपका रिक्वेस्ट आया है, आई थिंक हरप्रीत सिंह जी एंड अजय जी, इन दोनों का है। और किसी और का अगर रिक्वेस्ट है प्लीज लास्ट डे बता दीजिएगा। अगर हमको एटलीस्ट 30 पीपल मिलते हैं हिंदी बैच के लिए, मिनिमम 30, so we can plan for a separate Hindi batch also. ठीक है? So once again, thank you, Dr. Deepak. That was wonderful to start the session and to start this training program first day. And yeah,
thank you, ma'am. So I was just, I'm sorry, 6 बजे तक नहीं, और भी टाइम है हमारे पास। मुझे अभी सॉरी मैंने गलत से मैसेज रीड किया। So if somebody wants to share something, even a personal life experience, या आप और कुछ पूछना चाहते हैं तो please feel free to ask. We still have more time. So sorry, मैंने गलत मैसेज रीड किया था शायद।
तो मैं बात कर सकती हूँ?
जी जरूर, बोलिए।
हाँ, तो मैंने जो शुरू में क्वेश्चन पूछा था कि फाइनेंशियल एस्पेक्ट, तो उसका रीजन ये था कि आई हैव बीन वर्किंग विद एन एनजीओ इन हेल्थ केयर फॉर लास्ट 20 years.
What is the name of the NGO?
It's Samavedana in Pune.
Okay.
Yeah, and we used to give financial aid to patients who need specialty care.
Right.
But we always declined palliative care because the trust believed that when the funds are coming from society, it should go to a patient who is going to lead a normal life after the treatment.
Right.
So that contradiction was always there.
Right.
But still palliative care was the need, and we referred them to Cipla Palliative Care Center and all those.
Yeah.
See, we have seen so many patients who, like you mentioned about Mrs. B, who sell everything of their individual life, and then they are almost bankrupt. They have to shift to big cities and ruin their lives and entire family for the want of money.
Right. See, one thing is, मैंने इसको highlight, I mean, I have not highlighted it properly. ये फहमी से मत जाना कि पैलिएटिव केयर मतलब कैंसर के लिए है। ऑफ कोर्स मैंने यहाँ पे 2 जो केस यूज किए हैं वो कैंसर के हैं, क्योंकि कैंसर में जो फाइनेंशियल इम्प्लीकेशंस होता है, बहुत कम समय में बहुत ज्यादा पैसे लेके जाता है, वो ऐसा डिजीज है। सॉरी, ओके। सो देयर इज in cancer, don't be under the impression that because I have used the example of cancer, it is not just cancer which qualifies for palliative care. Majority of the diseases which require palliative care are non-cancer illnesses. That is, cancer ke alawa there are other diseases like diabetes, hypertension, stroke, different kinds of illnesses which happen, डिमेंशियाज, ओल्ड एज में जो भी दिक्कतें आती हैं, बच्चे लोग जो बर्थ इंजुरी के वजह से जो कंजेनिटल एब्नॉर्मैलिटीज प्लस बर्थ रिलेटेड इंजुरीज जिसके वजह से वो मेंटली इनकैपेसिटेटेड रहते हैं. So many disorders are there which requires palliative care, because palliative care is looking at quality of life, and quality of life can be given in different ways. And I can show you many cases where हम जो symptom manage करते हैं, यानी कि disease cannot be treated. The doctor knows that the disease cannot be treated, but suppose because of the disease some symptom is happening, that is there is severe pain, or there is always vomiting, or something else the person is not able to do, like for example not able to walk, or doesn't have enough balance, or so many other issues which they may be having. So our objective with this multidisciplinary team is to make sure that the person gets as normal life as possible. So with that, we have so many people who work on a daily basis just because of the medications they are having from us. So there are people who are on painkillers for the whole lifetime, but we know what is the maximum dose which can be given. So we make sure that we take care of that aspect, and they can continue working, they can continue having a family life, and despite of the disease being there, we do the treatment. And ma'am, I'll tell you one thing, many a times for palliative care, if the diseases, if they come to us early, like we said, many of the times, unfortunately, at the end only they come. But if they come to us early, we can start them on small doses of simple medications, because of which they can sustain a good quality of life. See, and I'll tell you one thing, palliative care patients की जो इच्छा रहती है, or their desire is not some big desire. They would want to have one night of proper sleep because they haven't slept for many months or days. They would want to swallow their food without having difficulty, or it will be very simple things like that. See, there is somebody who's underwent chemotherapy, radiotherapy, the whole mouth is become dry. It may be simple things like that which need solution. Okay, so these things require very less money compared to what a chemotherapy or a life-saving treatment needs to be done. So when I always argue that palliative care needs only such a small amount to sustain. If that small amount we can give, yes, it is not a dramatic thing. Okay, when something wrong is going to happen, imminently when something dangerous is going to happen, and if you save that person, then something dramatic happens. Okay, but beautiful things or things in life is not like that. All these things happen slowly. The progression of a disease also happens slowly. But on the day-to-day thing, there are many things which we can contribute to, which takes only less amount of money. So I would request, like, if you could have a discussion, probably we can meet separately with you and deliberate on how to do it. That palliative care, if it is included, there are many people whom you can functionally support on a day-to-day basis with small amounts of money. And of course, it doesn't have to happen through you. Probably it will be through a network of volunteers through you, and they can do the fundraising for it themselves. So we can explore, ma'am, in the future.
Definitely, yeah.
Kalpana ji, you have raised your hand.
Namaste.
Namaste.
I would like to say that unfortunately, there is still a lot of misunderstanding and myths about palliative care. People also choose how they want to live. And when somebody, I mean, if you try to suggest to somebody that they should take some medicine or something for palliative medicine, then they start saying, I mean, I have seen such cases where the patient's husband would say, no, they only put her to sleep, and she has been so active and she must be active. So there are a lot of difficulties, even the doctors and other patients. I mean, palliative care is not referred to when it ought to be done until it is very late. As you said, terminal or palliative care is often understood only as end of life, when there is nothing else. It is hopeless. And now we want to put them into palliative care and things like that. So even in society at large and among doctors too, I think there is a need for a lot more awareness about these issues.
So it is a process of evolution. It is gradual. In India, even though palliative care has been there since over nearly 3 decades now, but still it's a large country, and even in many other countries where this is accepted, these misconceptions exist. So the thing is, it is an ongoing process, and it is a approach. I mean, it's an effort which many organizations is trying towards. So there is something called as palliative care advocacy, which we do for patients. We do awareness sessions. We are doing above downwards approach also, that is from the level of, people who are in the positions of power to down to above also, that is from the grassroots level, starting at schools, starting by engaging with the community and building upwards. So there are different approaches and it's an ongoing process. So like you said, a lot of work needs to be done. Dr. Pankaj, you have raised your hand first.
Yes, sir. Sir, we are running an NGO which is managing non-malignant patients without malignancy for palliative care.
Right. Where are you based at?
We are not Navi Mumbai.
Navi Mumbai. I was born there. Okay.
Yes, sir. We are having a center at open for the last 9 years.
What's the name of the NGO?
The Geriatric Health and Care Foundation.
Okay.
We are getting difficulty in patient financial issues.
Right. Right. So, yeah, please continue.
The family is saying that they are not having malignancy. We are having patients of diabetes or dementia.
Okay.
This type of patient taking care, we are having support from our friends who are without any charges, they are giving services. But when in terms of monitoring the patient care, food and all, the relatives are not paid actually.
Right. Right. Yeah, sir, it's a common problem that relatives also are able to support only to one extent, beyond which they may not be able to support. And this is exactly where volunteers come into the picture. In the sense, what your organization will also have to do is identify those individuals within the community who are looking to do something voluntary. And that may be either contributing money or contributing those services or things which money can buy, for which money is required. For example, we have certain situations. I mean, in Kerala, there is a panchayat program like that also, where a neighbor cooks food once a day or twice a day and gives it to the patient who is debilitated. So that is there as a government project as well. But apart from that, we have some individuals also who anyways they are cooking for their family, and giving one-time food to a neighbor is not a big problem. So it is something as simple as that. There is a paraplegic woman who is paraplegic, means she is wheelchair bound, and she finds it difficult to move around within her house and do things. So somebody cooks and brings food to her and gives once a day. So they do it just once a day. That's all that they can do. But she's happy that at least once a day she doesn't have to cook. She can relax at that point of time. So forming a network of well-meaning individuals, of people who want to do something, is something which we'll have to look at mechanisms of how to do it. And there are ways to do it. It may be through cooperative housing societies. Now, Mumbai is a place where there are so many buildings, and buildings there is cooperative housing societies. So talking to the president of that society, presenting your case to them during a monthly meeting, or talking to the local corporate, what's it called, corporation officer, who will make sure that whenever there is some common meeting like that happening where general public is involved, they give you a platform. So things like this, we may have to look at innovative ways to approach people, to make ourselves aware that this is what we do, and then link these people to the patients who require these things. This is a large exercise. It is not easy. It will need planning, strategizing. You may need to have your own probably YouTube page or a social media page or something like that. A presence has to be there, that for which when people they search, they should be able to see कि अच्छा इन लोग ये सब काम कर रहे हैं. क्योंकि आज के दुनिया में अगर आप कुछ भी देखेंगे, the first thing we'll do is Google it, search it, and see whether this is there or not. So these are the kinds of things which you may have to strategically work on. Plan karke you may have to work on it.
Thank you, sir.
Thank you. Sajan Isaac, sir, you had raised your hand next.
Good evening, sir. Sir, I'm Sajan Isaac. I'm a medical social worker. I'm based in Ludhiana, Punjab, and I'm working with CMC Hospital as a medical social worker there. Right. So I have seen that there are no, much palliative care services are not in Punjab, Ludhiana side. So as a volunteer, what I'm trying to do is I have contacted some of the hospitals, like Cancer Hospital is there, Osol Cancer Hospital, and from there, some some people who are having life-threatening diseases like cancer, and they are the only person who is earning in their family. So what we are trying to do is, my father is having his own NGO. So in there is one program, Skill India, Jan Shikshan Sansthan. It is government recognized project. That is, if the person is the only one who is earning in his family, so if he is not earning that time, so we can give skills to them, to their family, either to their wife, or program consists of motor binding projects and electrician projects. Yes, sir.
No. Continue. Please
And
continue.
yes, Usha Selai machine projects are also there. So we are teaching them how to Selai, do Selai and all. So this is how I'm being a volunteer for them. Till now, we have not started yet, but I have already spoken to the hospitals and the head of department of those hospitals, that we can just sign an MOU, and we can start a program that those who need help, like financially we cannot give them, but we can give them skill training programs, so they can be just they can have some skill and they can earn by themselves. Yes, this is how I'm being a median for them, and as a volunteer, how I can help in palliative care.
Right, wonderful. So this is what, this is a very good example of what we call as a vocational rehabilitation, where we are trying to rehabilitate a person to give them some skill with which they can earn their own living. So in our case, one of the example which I highlighted was a vocational thing. I mean, was a poultry farming. Petty shop setting up is one of the other things which we do now. Like you said, to do the saline water management, this is something else which is there. So it depends on, many things depends on what is available locally. Now he knows that over there is something like this which can be done, and he has taken effort to do it voluntarily. Same way in your area, you may have to identify, or you through your network of friends or office people or professional contacts which you may have, there is something which you can find out and figure out what is it that you can do. And mind you, this is not always only for the patient. Many a times, the patient may have passed away, or the patient is unable to go to work anymore. So you may have to think of their children or their wife or their spouse or whatever, somebody else in the family who can take up a job and who can start being the earning member of the family. Even making ways for them is a way a volunteer contributes. So Sajan, thank you so much for sharing that. This is exactly a very good example which I think people can think of, that what is the importance of it also.
Yes, sir. And I'm really looking forward how we can bring palliative care services in Ludhiana, Punjab, and through what medium I can do that. And I am writing some of the articles also for to publish them, and for creating awareness about palliative care and how important it is in our sector.
Right, wonderful. Looking forward to working with you in some capacity or the other. Sunanda ji, you can note down. I am sure you would have already noted down.
Yes, already there. And we actually just wanted to tell you that Parliament works pan-India. So we have coordinators in different places. So for Punjab, we have a coordinator. So I'll inform him. And you've already shared your mobile number, is it, Mr. Sajan?
Yes,
you can do that. So we'll catch up with you. No worries.
Sure.
One of the questions is Ms. Manchi Joshi has asked, is there any existing system by which patients and volunteers from same area gets connected? As far as I am aware, there is no such a common system or something, but like some people have been sharing over here, it is all NGOs, different kinds of NGOs who work towards these kind of activities. but I'm not sure if at least as far as I am aware, there is no existing system as such where a patient can get registered and a volunteer can get registered and things can get connected between them. Sunanda ji, is there anything like that which you may be able to throw a light on?
As I said, we just started from Maharashtra, and it's nothing to do with registration. You have to just join hands and let's see. It's actually, you know, learning from each other and how we can figure out what can be done. So we can also start for other states also. But it, you know, what happened, why Maharashtra came into picture, because after similar volunteers training, I got a lot of calls from people all across Maharashtra that we want to help, we want to, now we are trained. So that's how, when we had a lot of people, then we thought of forming a group, and then, you know, you can say, like, you know, formalizing it. So we are also expecting after this training, if you get together, I mean, why state-wise? Because when you're in a particular state, then working would be, you know, easier, because the state scenarios differ. So that's the reason. So we can figure it out. Let this training get over. Maybe on the last day, we can just see what we can do, and maybe form different groups state-wise. Let's see how it goes. Thanks.
Right. So this
Can I come in, please? Can I come in?
Yes, please, Umesh sir.
See, there is a way out there. In every locality, there is a general practitioner association. So all the general practitioners have some senior patients with with the diseases which we discussed. So we can get in touch with General Practitioner Association, and anyone, any GP who has a patient, we can approach directly them.
Right. Thank you for the suggestion, sir. Like, I mean, we can look at strategies. We'll have to go in for deeper discussions as well. We'll note this down, Sunanda ji, and then we'll see that how we can include all these ideas and go ahead with different strategies forward. Thank you so much, sir.
Yes, thank you. That was a good suggestion. Thanks.
Pratibha ji, you have raised your hand.
Hi. My main intent of joining this session was to understand more about palliative care, because I'm creating content around it. And, you know, my understanding has been very superficial till now. And, you know, when I'm hearing you all talk, I am at this point very overwhelmed. You know, we are so busy in our life saying that I'm busy and I don't have the time for it. But when I'm hearing the stories of, I'm sorry, I forgot your name, the one who's in Ludhiana or Chandigarh, who said that you lack palliative care services. You know, these are the basic needs, and yet, you know, हम लोगों के पास टाइम नहीं है. जैसे आपने कहा कि आपको सिर्फ एक कॉल करना है दिन में, you know, उससे ज्यादा भी नहीं करना है आपको. एक कॉल करके सिर्फ पूछना कि आपकी हालचाल में आपके हाल ठीक है. I think, you know, if each one of us does this small thing, you know, we can really, really change so many things around in the perspective that we are living in. And, you know, thank you for this really lovely session.
Thank you so much, ma'am. Where are you based at?
I'm in Pune.
All right. I may be coming to Pune soon. I mean, maybe this month or next month.
Please, I would
have in
love
mind to have a meeting with you if possible.
I would really, really love to meet you.
Sure.
We can take this conversation offline also.
Sure.
Yeah?
We will.
Thank you.
Sure. Thank you, ma'am.
Thank you so much.
So I think with that, we'll come to an end right now. Now I have really overshot time. I did 2-3 minutes, but anyways, from 6:10 till 6:30. But I want all of us to, I mean, just one more reiteration from my side. I truly believe that human beings want to do good for each other. Yes, like Pratibha ma'am was saying right now, we get busy and life takes us ahead and we are busy with our own things. Usually with retirement life or something like that, you know, we get some more time at hand. And then comes the desire that ki kuch karna hai, something extra needs to be done. At least usual circumstance mein aise hi hota hai. But I'm very glad to see that a lot of young people also on board, like Sajan here, multiple people I can see over here on my screen, young people who are into this for a cause, for volunteering. And, you know, volunteering is just a process where we have become willing to do something where the calculation of what about me is not there. Mujhe isme se kya milega is not there. But just the fulfillment of providing something for somebody who is handicapped physically or mentally due to whatever reason it be. Somebody has asked about substance abuse also. Yes, you know, even facilitating or making connection between a person who is having substance abuse problems to a psychologist or a psychiatrist or a support group. You know, just like how Alcoholics Anonymous is there, just like that, if there is a support group which people are aware of. And see, these are not things, all these are not things which one person may know. These are all things which multiple people may know. And that is why it is important that all of us come together as part of a group, so that different ideas, different, like Umesh sir gave an idea right now, it can be a strategy going forward. So like this, multiple brains need to come together to contribute towards a cause and brainstorm on things and create systems for it. So I think, yes, we are on the right track and there is still so much more to do. Hopefully one day we can start, we'll start getting to see the results of it also. So with that, I will rest my case for today. And all the best to each one of you. We'll meet again, and do continue being active for the remaining sessions also. Be in touch with Sunanda ji for those of you who want to do more in this arena. I'm sure that we'll be able to find out some or the other way to do it or mechanisms for it. Thank you so much.
Thank you, Dr. Deepak and Sunanda, for being here with us today. Actually, Sunanda lost her network connection and she is out of the group now. Thank you all for joining for today's session. Tomorrow we will be having a session on communication. That's one of the most important topics in palliative care. So I have shared a feedback link with you all in your WhatsApp group and in your chat box. Kindly go through it and fill it up. Thank you all. Bye-bye.